So let's call the meeting to order. Let's take roll with an identification of the voting members, please. You want, Winnie, you just want to go around and call out people's names as you see the participants so they could identify themselves and identify whether they're the voting member or not.
Yeah, I'll go ahead and do that. Winnie's having voice issues, so I'll go ahead and save her voice a little bit, and maybe I'll just go by who's on my screen.
Okay.
Okay, so I'm going to start with the city of Culver City.
Good afternoon, Alex Fish, voting member here for Culver City.
Great. And I think that's it for Culver City on electeds. City of Santa Monica.
Sue Himmelrich, I'm here as a voting member for the city of Santa Monica.
Bill, you're on mute.
I am.
No,
I'm not.
alternate for
Yeah.
Santa Monica.
Great, thank you. City of West Hollywood.
Lauren Meister, I'm the alternate voting member.
And I don't see anybody else from West Hollywood.
I see Corey Plank.
Yeah, but not on a member.
Oh,
And
no.
then-
I'm the alternate today. I'm the voting member today.
And then City of Beverly Hills.
Julian Gold, I'm the voting member.
I don't think we have anybody from the city of Los Angeles or the county of Los Angeles as a member or voting member.
I am Tony Williams. I am not a voting member. I was invited by Winnie to attend, but here to help out how I can.
Great, thank you. Okay, so those are our members and our voting members. And as we often do, we ask others who are present to introduce themselves so we know who's in the room. And we'll start with our guest today. Karen, go ahead and introduce yourself.
Hi, everybody. I'm Karen Linkins, and I'm the Chief Strategy Officer for Mindosi Be Well in Orange County.
Welcome, Lauren Langer.
Sorry, the double mute. Hi, good afternoon. Lauren Langer, counsel for the COG.
Cindy Owens. Okay, well, Cindy is with the City of Beverly Hills, the manager's office. Shelley Wolfberg.
Yes, Shelley Wolfberg, assistant to the city manager for City of Culver City.
Corey, I'm queuing you up now. Go ahead, Corey.
Hi, good afternoon. I'm Corey Plank. I'm the Strategic Initiatives Manager for the City of West Hollywood.
Thank you. Anita, go ahead.
All right, for your video.
Oh, we have Elizabeth Anderson here as well from West Hollywood.
And I am Anisha Clark from the City of Beverly Hills Human Services Division.
Beautiful. Ana Cuevas.
Hello, I'm Ana Cuevas, and I'm here on behalf of the West Side City of Culver.
Anush, go ahead.
Good afternoon, everybody. Anuj Gupta, Deputy City Manager, Santa Monica.
Thank you. Elizabeth Anderson.
Hi there, Elizabeth Anderson, City of West Hollywood.
Thanks, Elizabeth. Arams White, Sheeran.
Good afternoon, everyone. I'm Aramis White Sheeran. I'm with the City of Culver City, assistant to the city manager on homelessness.
Thank you. Margaret Willis.
Maggie Willis, Housing and Human Services Administrator for the City of Santa Monica.
Great. Sergeant Carlos Jane.
How are you doing? Sergeant Carlos Ian, sergeants with the SMPD oversee our homeless unit.
Great. Rachel Evans.
Good afternoon, Rachel Evans with the City of Beverly Hills, Human Services Administrator.
Thank you. Sharona Nazarian.
Hi, I'm Sharona Nazarian, City Council member.
Oh, welcome. Great to have you here.
Thank you. I'm an alternate.
Thank you. Isela Gracian.
Okay, sorry about that. Hi, everybody. I'm Isela Gracian. I am Senior Deputy Housing, Homelessness, and Planning for Supervisor Holly Mitchell. I'll have my camera off for a little bit because I'm just having lunch and then I'll join you via camera.
Thanks,
Great to join you.
Gabriella, yeah.
What's for lunch?
Hi, Gabrielle Yap,
Nachos.
Deputy City Manager for Beverly Hills.
Thanks, Gabriella. Amanda Reese.
Hi, I'm Amanda Ruiz. I'm a Senior Deputy of the Intensive Care Division for LA County Department of Mental Health.
Wonderful. Welcome. Achi Stevenson.
Everyone, Shay Stevenson. I am a Senior Human Services Analyst with the City of Santa Monica.
Great. And then Winnie.
Project Director at the West Side Cities Council of Governments.
We're trying to preserve Winnie's voice today. And I'm Cecilia Estolano, Executive Director of the West Side Cities COG. And with that, I am going to turn it back over to our chairman, Dr. Gold.
Well, thank you very much and welcome everybody. It's great to see so many people on this call. We certainly appreciate everybody's attendance and hopefully everybody will find this productive and help us find a way forward. We have one piece of housekeeping in advance of the presentation. And this is an action item number 3, an authorization to conduct teleconferencing meetings under the AB 361 Act. And we need to make some findings. I don't know, most of us have been around this thing 100 million times. So Lauren, I'm going to leave it to you. Can I just accept a motion in a second, or do we have to read it?
It's fine to accept a motion in a second because it's printed on the agenda.
Culver
Fantastic.
City moves to make the findings and the authorization.
Thank you. Is there a second?
I'll second. West Hollywood.
Fantastic. Is there we need a roll call, please?
Yes. City of Beverly Hills.
Yes.
City of Culver City.
Yes.
City of Santa Monica.
Yes.
City of West Hollywood.
Yes.
City of Los Angeles. County of Los Angeles. Okay, motion passes.
Thank you. So we move on to the meat of today's meeting, the presentation and discussion about behavioral crisis and mental health services. We're fortunate today to be joined by Karen Linkins, Dr. Linkins, who is the Chief Strategist for the OC Be Well and Be Well OC. Dr. Linkins has a long history, 25 years, planning, technical assistance, program evaluation, and just general experience in the areas of home and community-based services, integrated behavioral health, mental health systems, and on and on and on. I'm not going to read it all. Her bio is lengthy. I think it's more important that we hear from her. So Dr. Linkins, thank you for joining us today, and I'm going to turn this program over to you. In advance of it, I'd just like to suggest that in terms of the management of today's program, because it is complicated and long, that this be broken into pieces. We'll kind of take questions after each piece. There are 3 that are suggested: a regional system framework, campus facilities, and a Be Well mobile program. Those 3 things. So if we can hold our questions on the first section until after the first section, and so forth and so on, I think we will get through this most expeditiously. So if everybody's okay with that, I'm going to turn it over to Dr. Linkins.
Great, thank you. It's really wonderful to be here today. I always like the opportunity to talk about the work that we've been doing just south of you. And we are hopeful that that what we've been doing is actually something that will catch the imagination of other geographies, and that we can scale and spread the model. And that's all to say this is still pretty new and developmental, and that's kind of my caveat here. We're still learning, but I'm really excited to be able to talk with you all today about it. Back in 2018, it was about 2018, it might have been 2017, in Orange County, just like in many communities, there was the typical finger pointing that was going on between among the cities, among the county, and the hospitals. And it was all around, we have people with mental illness and substance use issues who are showing up in the emergency departments, and the hospitals would say, these are not our people. The county would say, well, these are not our people, and there's lots of finger pointing. And, for the cities, they were most impacted by, the unhoused population, or just, I mean, every sector is affected by behavioral health issues. And so we had kind of an amazing opportunity where people calmed down and there was a conversation. And the conversation led to what I'm going to be presenting today, which is Be Well, which is we call it the Be Well movement of Orange County. It's a collective impact approach. And the mission is optimal mental health and wellness for all Orange County residents. So we are, and we mean that. This is really supposed to be kind of payer agnostic. We're trying to build a system. We're trying to not do away with the carve out, but get around the carve out and create more of a system of care so that if you, regardless of your needs, you're able to access services. And then, the vision is pretty aspirational. We want to build Orange County's world-class mental health system. And as I started off saying, we do think that this model is translatable to other communities because it's really approaching the issues that everybody's facing. Next slide, please. So this gives you a visual of what we see as the problem, and it probably resonates with you. The fragmentation and silos across the sectors have led to a lot of residents who are unserved, underserved, and often inappropriately served. So here you can see, we've kind of called out with the little people. You can see we have the continuum here of moderate clinical need to serious and persistent needs. And then the uninsured, the commercial insurance, all of that. And then those little flags give you a sense of the range of sectors where that are touched by mental health and substance use, and also often work in the space of substance use or mental health and substance use, but they're not coordinated. That's kind of our hypothesis going into this, that we actually need the sectors to come together and come up with a shared vision and shared solution to the problem. And I don't know who's driving this. Winnie, are you driving it? Because there's another part of this slide. And so the idea is that this fragmentation has led to increased crises. Basically the default that, in Orange County, we don't have a public hospital, and really the largest psych facility is the jails. And, this is like all the different things that are just not coordinated and are a problem. So next slide. And this is where we get to the solution. So you can see how the fragmentation, the solution is to bring it all together and have it be better aligned and coordinated. And that's sort of the idea around collective impact. It's where the range of sectors and organizations and people come together with a shared vision, moving in the same direction, agreeing that, we in Orange County have so many resources, but they just are not well aligned. And so that's where the picture on the right is really giving you a sense of the system of care that we are trying to build. And it's multidimensional, multi-sector, but it really, the idea is that it can be payer agnostic, and we really are wrapping services around the needs of all residents of Orange County. Next slide. So in 2018, we started a more intentional conversation around this. I talked about the finger pointing that people got over in 2017. In 2018, we had probably 100 people coming together to weigh in on what we are calling the blueprint. And we developed the blueprint to give us a framework and give us some actions to move toward this system of care, this more coordinated system of care. And at this point, in 2018, we started forming what we call the Be Well Coalition. And today we have more than 400 organizations participating and almost 2,000 individuals who are, part of what we call the coalition. And on the left-hand side, this is kind of the heart of the blueprint. The flags that you see are our result areas because we've set this up so that we have results-based accountability. We are leading the work toward addressing these as outcomes. So the outcomes are reducing stigma, preventing and acting early, closing the treatment gaps and improving access, strengthening the crisis response system, establishing community wellness hubs, and aligning partners, policies, and programs. And I know that I use the word alignment a lot and I use coordination, but that's really like that is what we are doing. And today I will be talking more deeply about strengthening the crisis response and what we've been doing in that space, as well as establishing the community wellness hubs. But in addition to this, you see in the center, MindOC, which is the backbone, and that's the organization that I work for. And we are, this is really coming from the collective impact model, where that it says that in order to, bring together all of the sectors, and get them aligned and working in coordination with each other, there does need to be a neutral entity that can do that. It's not really something that the county could do, not really something that the cities can do. We have 34 cities in Orange County, so MindOC is a 501c3 that was formed expressly to support the work of this, initiative. And then you can see that in addition to these result areas that are on the left-hand side, we do have some special initiatives we've gotten on behalf of the community, and we actually involve partners in this work. So we have one on our trauma-informed network of care, and that was actually ACE's funding, ACE's aware funding that we got from the Surgeon General. And we have about 25 organizations that are involved in that work. We have a community suicide prevention initiative that actually involves, that's Cal MHSA money. And it is involving many community-based organizations in the schools and that sort of thing. And then also we have funding from the state. It's actually SAMHSA funding on youth opioid response. So I just wanted to give you a little flavor of, in addition to these big chunky areas, we do some very specific grants that are strategic, and they are meant to help us make progress on these result areas. Next slide. And so this is really where we're going, because in addition to what I just kind of showed you, we have what we are considering the, kind of the infrastructure that needs to change. It's the transformation infrastructure for, that will help bring things together in Orange County. So as part of this, we are aligning the work of the county, CalOptima, our health plan, or Medi-Cal managed care health plan, the hospitals, and these are, primarily nonprofit hospitals, the cities, private stakeholders, and MindOC. And together we are working on this infrastructure around navigation, right? When we started this work, there were 18 different crisis lines that you could call to try to get services, but nobody could ever figure out, who do we call if we have an issue? So there's navigation. How do you navigate the system? There's mobile response. We have, the county has crisis teams, but they are really around 5150, like very extreme crisis, as opposed to the work that we are now doing in 5 cities that I'm going to be telling you about. The regional campuses, which is that result area that I showed you, that is the wellness hubs. And then undergirding all of that is really trying to better align providers. I mean, there are lots of networks, the health plans have networks, the hospital systems have networks of providers, but they're not well coordinated and they're not integrated. And so it's kind of working with all of our partners to start thinking about how can we do this differently. And I think that that's my last slide on this section. So if you want to ask me any questions about kind of this overview, I'm happy to answer.
All right. Are we gonna, if we get rid of the slides?
Yeah, you have Mayor Himmelrich in the queue.
I beg your pardon?
Mayor Himmelrich, just raise your hand.
Okay, Mayor.
Thank you. And thanks so much for being here today. I love that we're looking at this. So you talked about a single Medicaid plan. Is that, I know in LA we have 2. Do you only have 1 provider in Orange County?
No, we have, we're like LA Care. I mean, CalOptima is like,
because we have,
yeah.
right.
Yeah, because so CalOptima is like LA Care, and then we have Kaiser, as kind of another, but we are a single plan county operated system.
Okay, that was my question. And I do some work around Medicaid. And I wanted to ask about something you just said. You talked about what I've always thought. So I always say people need a navigator, but what you're talking about is basically creating a system so people wouldn't need a navigator, so the outreach is comprehensive enough, or is that wrong?
It's a little bit of a both and, because we haven't come in with a full solution. We actually are exploring, what does navigation mean? And, different people need different navigation strategies. Some people actually need someone to physically help them through. Some of this can be done electronically. The county behavioral health has outreach and engagement, that's kind of street outreach and that sort of thing. So that's helping with navigation, connecting people to services. So it's at a number of levels. And the reason that we have it there is that it is really critical, but we need to do some sense making of it.
Thank you.
Mm-hmm.
Anyone else? I have a couple of questions, if not. So 2 parts. Actually working amongst giants, right? LA County, as a giant organization. First off, I applaud you and I applaud Orange County for getting ahead of this and trying to put the pieces together in a way that makes sense. Candidly, I'm not sure that LA County is even close to that. There's lots of money spent in lots of programs that don't touch each other. And I think a lot of waste as a result of that, and certainly no integration. So my first question to you really is, how do you sort of align all of the county agencies, which are now vested with their millions or hundreds of millions of dollars? How did you align those folks to cede some control of that to a greater good? What was the secret sauce in that?
Well, I don't know that I have the full secret sauce, but I do think that, part of it was creating a table where we brought entities together that typically didn't talk to each other. And we were able to facilitate the conversation such that we could get some buy-in. But, this is still a journey. I mean, every day, trust has to be maintained and built and that kind of thing. And so part of it, I think, was starting on specific projects. So when I share with you what we're, the work that we did on the wellness campus, that became a way to coalesce the different agencies and entities to participate. And, it was the same kind of thing, getting the hospitals in the same room so that, because they compete with each other. And, we were able to bring them in a way that, at least on this topic, they weren't competing as much. And I say as much because, we're still not perfect. It's still a journey.
Right. Well, that was actually my second question, which was as complicated as the county services are. Getting competing health systems to get in a room together is really like, you have to check for weapons. So, and maybe of mass destruction, but so you have your health systems down there are cooperating with each other. They're going to share patient records and visits and all that kind of stuff, or what are they doing?
No, not yet. No, where they came together was around coming up with a solution for an immediate problem, which was overcrowding in the EDs with individuals with mental health and substance use issues who really had no business being treated in those settings. I mean, it actually exacerbates their issues, and they could agree on that. And so, but they're not sharing data. We haven't created we haven't gotten to the place yet where everything is, harmonized. we aspire to that, but in a lot of ways, the way that we approach this is to say, we're not asking you to not do your work. We're actually asking you to do business differently insofar as you can come together and collaborate and coordinate. You can still, kind of do your own specialty work, but it's really as simple as that. So because we can't boil the ocean.
Right. Well, and this is the ocean. My sense of it is, because most health systems have diminished their mental health services, their mental wellness services across the board. If you offered an opportunity where they could augment that, but subsidize that cost through grants or federal monies or other things, they might find some interest in that because their costs would go down and they would provide a service that they're going to be mandated to provide at a lesser cost. So I think in the end, like most things, you might be able to convince them with money, but to be determined.
Yeah, and to your earlier point, I mean, our county behavioral health, I think that when we did the assessment, there were over 200 programs that are funded under MHSA that have nothing to do with each other. I mean, they're not done, it's like they're grant by grant by grant, and they are not done strategically. And so in a lot of ways, even for the hospitals and the other systems to understand what was going on with those programs became a big conversation, because part of it was around, can we actually start partnering and use these resources in a better way?
Right.
And again, that's still a process.
Right. Isela?
Dr. Gold, you have Isela Gracian from Supervisor Mitchell's office in the queue, as well as Mayor Himmelrich.
Okay.
Thank you. Thank you for that presentation. Super helpful. I have two questions. Definitely really appreciate that you all laid out that North Star and providing mental health services for all. So my first question is connected to that piece, the all, because I think every jurisdiction and just generally society, we're dealing with like who's deserving, who's not deserving of services, and that tends to definitely boil down to whether people have money or not, or race, ethnicity, culture. So one piece I'm like really curious to hear about how the reach of the services, if there's any impact now, particularly like in Orange County. I think a lot of folks think about it more monolithic, but there's like Santana and other pockets of lower income communities and people of color and more migrant communities. That's one question. And then the other question is, have you all gotten to the part of the guidelines and specificities of some of the funding? Because that's one of the areas that at the county we're looking at, particularly digging a little bit deeper in establishing the Office of Prevention and really understanding like what are the hard line limits on the intersections of dollars and where there's some room there, but we're in very early stages. So I'm just curious if you are further advanced within this sector on that challenge.
I'll answer that question first, and then I'll get to the equity question. I would say that we're probably in a pretty similar situation. We certainly have not solved all of that. But one thing that actually did happen yesterday that is very unique is that the Board of Supervisors voted to grant Mind OC, the little 501c3, management services agreement with County Behavioral Health, where we are assuming the risk for some of the services that are being delivered at the campus that I'm going to talk about in a few minutes. And what that means is before we had this management services agreement, we effectively were running the campus, but we were like landlords. Now we actually have responsibility and oversight and are going to be getting into the compliance piece of managing the clinical services that are contracted at the site. And so that's kind of a new way of doing business, and it's a new way of thinking about the resources. And I know that doesn't completely get at the question that you're asking around that, but I wanted to just kind of illustrate that as some of the thinking. I think that there's a willingness among the electeds as well as the departments under the healthcare agency to think about things a little differently. And this is also in the context of public health and prevention and so forth. So it's, we don't have the answers, but there is movement, I think, in the right direction. And then to your other question, we are very committed to serving, like building a system that's actually responsive to the needs of all Orange County residents. And we do have several of these. I showed you some of the special initiatives in that on that other slide. Those are targeting some of those, the more impacted communities, especially those that were really impacted by COVID. And we've been collaborating with the county on that as well, and with public health. because that's given us a lot of insights into those communities. And we very intentionally partner with community-based organizations because with the whole idea of collective impact, we know that we can't do it all. And I didn't go into it on the slide where I was showing you the result areas, but there are some little gray circles around each of the result areas. And that's really in recognition that, you know, as the backbone organization, we can only do so much. We also need to use distributed leadership to engage the community. And that's a very intentional strategy that we have. And then with those special initiatives, we are partnering with community-based organizations that typically would not be able to access those dollars. They don't have the resources to apply for, you know, for those dollars or, you know, that kind of thing. And so that's part of how we are really trying to put equity at the center of this.
Dr. Gold, we are at time for this section. We have both Mayor Himmelrich and Councilmember Fish have their hands raised. I'm wondering if we can go to the next section, and if y'all could hold your questions, would that be okay?
You guys okay with that?
Mine is not a question, actually. If I can just say this, because I'm not going to be here. For those of you who don't know, I'm not running for office again, so I'm going to be gone. But we have already convened the four, and I'm saying this to Dr. Gold, he is a doctor, and maybe we have convened the four major healthcare systems in Santa Monica. On the west side, we convened Providence, UCLA, Cedars, and Kaiser, who have agreed to work together on this as a West Side project and to fund it as a West Side project. We did that initially as part of something that was going on in Santa Monica, but what I think we need to do is be sure to drive it forward. So for those of you who are still here, when I'm no longer in office, this is something that we need to persist in and not let it go. All of these things rely on determination and persistence by the people who want to see it happen. So that's all I want to say.
Thank you. I appreciate that. Keep our fingers crossed. Karen, back to you.
Okay. So now I'm going to talk about the campus, and I just gave you, you know, kind of the punchline, which is as of yesterday, everything has now changed, and we actually get to have oversight of the services, which we're thrilled about. But you can see here, this is a picture of the first campus that we're building, that we have built. We broke ground in 2019, and then actually, I'm sorry, yes, it was 2019. And then we opened services in January of 2021. So it was definitely a pandemic project. But the idea of this campus is that it's promoting wellness. And you can see by the design that it doesn't look like a typical county structure. And that's because, and if you could go to the next slide, we were able to convene a public-private partnership with the different health systems, as well as the healthcare agency, as well as CalOptima, the Medi-Cal managed care plan, to raise the funding for the building and to agree to go in on investing in it together. And so the county offered up the land and did about a third of the funding. CalOptima did a third of the funding, and then the nonprofit hospital systems did a third of the funding for a total of $40 million. Next slide, please. And the campus itself has these guiding principles, which, you know, we're very committed to, and these were actually co-created, you know, by convening the different sectors and saying, you know, if we have a campus like this, what do you want to see? And it was also with community members, because with everything that we do, we are engaging the community because we want whatever we are building to be responsive to the unique needs of the many. And so we have a commitment to serving all community members regardless of payer. The idea was that the environment needed to be destigmatizing and warm and welcoming and respectful. Collaborative of public-private partners to provide the new models of care. And that is, you know, again, the new models of care was really important to get at, which we can now do with the MSA that we have with the county. a place that provides hope and trusted support and supporting an integrated continuum of care and services. And then having an environmental aspect of it, kind of having indoor outdoor space. So by design, it's really bringing nature in and recognizing that that's really part of health and wellness. Next slide. So this gives you a bigger view of the campus. It is a 93-bed facility, but it's broken into 7 core service areas. Well, actually 6, but so we start with the recovery station. That's a sobering unit, and we have 12 beds there. And then we have crisis stabilization, and that's actually divided into 2 services. So we have beds for adults and beds for adolescents. And then withdrawal management, we also have crisis residential and substance use residential, and then mental health residential. So so it's really going from urgent care to longer term services. The mental health and substance use beds can go up to 90 days. And on the left-hand side, you can see that's actually a garage. It's a sally port, and that's where law enforcement and EMS can drive up, pull in, and begin the journey, begin the patient's journey in a very respectful and calming kind of way. So instead of transporting somebody to an emergency department that is loud and chaotic, the individual can be calm. They are pulled into the sally port, and is a very calming experience. And the other advantage with this is that law enforcement, typically if they are transporting somebody to an emergency department, they have to stay with them. And so it can be hours of time while they wait. It's the wall time. Here, the typical transition is about 10 minutes. So it's really worked amazingly well. And so people pull into the sally port, and if the individual needs crisis stabilization, they go to the CSU. If they need the sobering station, they go there. And these data that I'm showing, this is another kind of artifact of the relationship that we had that is going to change because of the MSA. We actually didn't have a very good line of sight into the data. And so we've always had to kind of work with the county around, what are the admissions and that kind of thing, because with HIPAA and 42 CFR, we didn't have the data sharing agreements so that we could know what was going on. And that will change. But this gives you a sense in a year or so of how many admissions we had and sort of what that looks like. Next slide. And I'm going to show you a couple of pictures. This is a rendering, but actually, in real life, the units do look this way. You can see that they are by design meant to have kind of a home feel and a kind of a feeling of sophistication. And we really see this as promoting dignity and respect for the people receiving care. Next slide. And this gives you a sense of some of the indoor-outdoor nature of this. You can't see it, but this building was built on a piece of land that isn't the most desirable piece of land. It's literally off the 22, and you can hear the cars and that sort of thing. But we were able to situate the building such that that's not the focal point, and we were also able to use land that a lot of people really would not want to build on. Next slide. So this gives you a sense of the model that we had before, where I was saying that, Mind OC was really kind of the landlord. We were getting our revenue from rent, and the clinical management was done by the county. And then the next slide shows you what our new model is. And so with this, we have, the county has delegated responsibility for contracting to us. We also will hold contracts. We have a contract right now for the sobering station with Cal Optima, because that's a new benefit under Cal AIM. And we also are going to be getting commercial contracts. And so, as we get the commercial contracts in on that left-hand side, you're going to see more commercial contracts. We actually have one with Kaiser, and we are in the process of getting more. And then the next slide, please. We are really excited that with support from the Board of Supervisors and the county, we are now beginning the process of planning for the Irvine campus. So that will be our second campus. And that is, if you go to the next slide, you can see kind of the layout of it. It is a very large parcel of land that is in Irvine. It's the Great Park. It used to be where the Navy had barracks, and you know it was an active military base. And we are really excited about it because with the space, we can actually replicate what we've done at the Orange campus, which is where you, what you see with phase one. It's effectively going to be those services, but then we're able to spread it out and start integrating additional services. And again, you know, kind of keeping that whole idea of the indoor-outdoor piece, but we also want to build this into, in phase three, a place that can really engage the community more, and it can be a public space that can really meet the needs of the broader population. We can get into more prevention work, you know, and things like that. Next slide. And so this just gives you a sense of the square footage. It's pretty significant compared to the Orange campus is kind of what it is because it was a small parcel of land. But here we're actually able to kind of reimagine what a mental health and substance use facility can be. Next slide. And I'm sharing these because, you know, we're just proud of it. We're excited about it. And again, we're carrying out that residential feel, you know, that indoor outdoor experience. And so with that, I will, I can stop for questions again.
Okay. I don't see any. Am I missing somebody?
I don't see anybody in the queue. Oh, Alex Fish.
Alex.
Thank you. You know, this is obviously overwhelming in many ways because and because of what you're doing, the scale and the scope and the fragmentation, and you know, Los Angeles has its own, you know, challenges in history where we've ramped up a tremendous amount, and there's coordination efforts that have happened and then been reformulated and redirected. And I just, you know, one thing that worries me is that we're always redirecting. How, I guess so it's hard for me to formulate this question, but how in that role of sort of convening and integrating and you know, relating, navigating, are you dealing with whatever was Orange County was doing before and the various efforts to reform that? Because it seems, I don't know if the experience is the same. It seems like one thing that affects us is that we're constantly trying to rebuild the plane as we fly. And I wonder if that experience was the same in Orange County.
Yeah, I think that that's still true. Earlier, I was saying that you really need a project, and we were able to bring folks together with the Orange campus and to agree, okay, co-location is a good idea. And, you know, we want to have this campus look different and we can have this public-private partnership, but that doesn't mean that we don't, that there still aren't other, you know, even potentially competing ideas and actions that are going on. But as part of, if you recall back to the blueprint slide where we have our result areas, that final result area is aligning policies, practices, and programs. And we have that because of exactly what you're describing. And so that creates another table to start talking about, you know, do we want to reinvent the wheel? Is this necessary? Are there other ways for us to align things? And I would say right now that's been pretty underpotentiated because, you know, all of this has happened pretty quickly. I mean, if we think about it, you know, we started with the intention of the blueprint in 2018, and we're 2022, and we've already done, you know, the campus. We have another one coming, and then we are, you know, trying to do a range of work. But COVID really sent us for a tailspin in a lot of ways because there was so much money coming into the community, and suddenly, you know, other organizations were receiving funding and trying to do different things and having a COVID response, which in a lot of ways was around mental health. And we had to really kind of stay on top of it and acknowledge that that these things were happening and there wasn't necessarily a very good strategy around it. And I would say that now Orange County is coming out on the other side a little bit. But, you know, I don't have a great answer for you because we just think of this as a process. And but I guess really the way that we approach it is just trying to stay on top of everything that's happening and you know, keeping our ear to the ground so that if we hear about something that, you know, the Department of Public Health is doing, like they have a giant equity initiative because of the CDC dollars that is actually, we are working very intentionally to make sure that our work is aligned with it, and that we're not duplicating or replicating what they're doing. And I think that becomes half the battle, because part of this is the reason why I use the word alignment a lot is that's you know, you need to make sure that that resources are that you're not stepping on toes and you're not stepping on top of each other and kind of going for the same thing. So not the best answer, but it's, you know.
Amanda?
I mean, you've done a really beautiful job of bringing a lot of different things together. And we've tried to do something similar with our restorative care villages. And one of the things I like to keep my eye on is identifying gaps in our network of care. And I'm wondering if you or if anyone else has seen or is looking at providing crisis residential treatment programs for adolescents, or if that's been identified as the gap in your network.
That's a great question. And that's exactly what we are going to be focusing on at the Irvine campus, because, you know, that is a huge gap in the service system of Orange County. We don't have adolescent services. We don't have enough. And this is where MindOC and some of our partners, some of the hospital partners and the county have been collaborating around the BCHIP funding that's available from the state. And so we applied and we were successful in getting funding from round 2 and 3. And then now we just applied for 4. So, you know, part of what you're seeing today is also the serendipity of the resources. It's that unprecedented, you know, time of resources. And we've been in a really good position timing wise, and just in terms of the maturity of our architectural work and that kind of thing. Like we're, you know, shovel ready for some of the applications. So that's been I think an important element. But yeah, crisis residential for adolescents is absolutely a needed service. And we also we want to do broader children's services. And then, you know, many like CHOC, the Children's Hospital here has identified a number of unmet needs for children and youth. And we are, you know, contemplating how we can bring those services into that campus as well. And the same thing with UC Irvine.
Thank you.
Have you, this is a kind of a granular question, but when you take a look at the dollars that you're accumulating, the people who are contributing to it, is it your expectation that you're going to return services proportionate to those dollars received? Or how do you decide with a limited facility? Is there a priority set by somebody who's donated more? What do you do with that? How does that work?
We're not really approaching it that way. I mean, there's a recognition, like, you know, with the entities that contributed to the Orange facility, where we had a third from the county, a third from Cal Optima, and a third from the hospitals. There wasn't an expectation that there was going to be like that dollar for dollar return on investment, anything like that. The Board of Supervisors absolutely has a lot of expectation that we are going to be leveraging the campus to not just be funded by county, you know, by county dollars and by state dollars, or public dollars. There's every expectation that we actually come up with a way to attract the commercial insurance plans to give us contracts so that we can serve the client mix that is more, commercially insured as well as publicly insured. But, we don't have any kind of restrictions or any kind of quotas from the different entities.
Yeah, I would, and I'd be curious to see how this develops over time. But I certainly could see a scenario in which one health system feels that they're being not considered equally as others, and frankly, I think because of the different demographics of the world in which they live, it's likely that would happen. So it would be nice to see if they can remain cordial and play well in the sandbox.
Yeah, and we do, I mean, in terms of thinking about access to the campus and, the access issues and referrals and that sort of thing, we've done a lot of work with all of the hospitals, not just the ones that actually contributed, to the campus, because it is really, the part of the reason, well, it was a large part of the reason of building the campus was to really take the pressure off of the emergency departments and to have alternative places for care.
Right.
So.
Thank you. Alex?
Sorry to come back to the well. And I'm sorry that, as an elected official, this stuff is often very confusing. And, we're just trying to figure out how to do good stuff and plug things together. But it sounds like what you're accomplishing is both expanding services, the filling gaps, and also providing some diversion. Is that accurate? And if so, are you able to sort of put any metrics? I know that's a lot to ask on the diversion aspect, like saving police time or time from enhanced detention, that sort of thing.
Yes, it's nascent at this point. We haven't done it as systematically as we are going to on the police side of things. We just know, kind of what the average is. That the wall time is about 10 minutes, that sort of thing. But we're actually going to study that more systematically. And now that we are going to be the entity contracting the services at the campus, we will be in a position to have much better line of sight into the referral patterns as well as discharges, because part of this is we want to incentivize this differently. We ultimately would like to be able to be moving more toward value-based contracting, which you don't have in behavioral health. With the county, it's cost-based reimbursement, and so the state is moving in that direction, but we are trying to build in those principles, and so that will also give us some of those diversion metrics, and the same with the emergency departments and that sort of thing. So it's we're kind of in our infancy. We've been open for about a year and a half, and we have some of the right conditions built in, but we are not there yet in order to get to the point where we're more data driven. When I show you when I talk about the next part, which is around our mobile, I will have some data to share with you.
All right, so let's do it.
Yeah, all right, right on time.
Great. Okay. There we go. So in August of 2021, we opened our first program, our first mobile program in the city of Huntington Beach. And the idea is that this is actually, we're in 5 cities now. So we're in Huntington Beach, Garden Grove, Anaheim, Newport Beach, and Irvine. And the cities are the entities that have paid for this service using an array of dollars. Some of it's HUD funding, some of it is pandemic related funding. But this is really a proof of concept that we are engaging in with the cities, and the intention is to actually spread it to additional cities. We started with a model out of Oregon. It's called the Cahoots model, and it is a model that by design is supposed to support law enforcement, EMS, and county response teams and the community. So the idea is that instead of deploying law enforcement, our mobile teams can go out and do the de-escalation. And typically, these are crisis calls that come into 911, And we are offering an alternative option so that law enforcement or EMS doesn't need to be deployed. And also the county CAT team, which is, you know, the entity that does the 5150s and that sort of thing, they're able to really focus on in a more targeted way individuals who are likely or who are more likely to need to have the 5150. We're really focusing on kind of that population that is just kind of new to crisis and it may be experiencing crisis, or they need welfare checks, that sort of thing. And this is non-emergency. And so when each of the cities, we go through the city dispatch of 911 to get the deployment calls. And they have protocols for deciding, you know, when they're going to engage the HOPE team. Next slide. So this slide basically, you know, says what I just said, that we're optimizing deployment of first responders and then the specialized county response teams. And so you can see this continuum that we're trying to build. And this goes back to that result area 4, which is improving crisis response. And so the CAT PERT is the high level, high need service that the county provides. And they also have outreach and engagement that, of course, is addressing individuals experiencing homelessness. And then Cal Optima is in the process of starting their own street medicine program. And there are also some of the FQHCs in Orange County that have street medicine. And then we have Be Well Mobile. And the teams that are on our rigs are it's a 2-person team, one with a background in behavioral health crisis management, and the other typically with some, actually many of them have served as EMTs, but this is not meant to be a replacement services for, you know, EMS, EMT. We just wanted to have individuals on the rigs who do have some medical background so that, you know, if they get on the scene, they can make a determination pretty quickly if somebody else needs to be called. Next slide. We had a phased implementation, as I mentioned. We started in August of 2021 in Huntington Beach, and then we brought online Garden Grove, then Newport Beach, then Anaheim, Irvine, and then that black line gives you all of the cities combined. That's how many people we had served as of August 22, and that was actually in the month of August, sorry. And then our total contacts over time, that's 7,756. The crisis call rate in Orange County is really, really high. And the CAT teams can only respond, I think that they respond to about 7,500 in a year. And so you can see that that just from these 5 cities, this is how many calls that we were able to respond to, because we're just a very different service from, you know, we don't have to do the whole protocol of the 5150 and that sort of thing, and that's not our purpose. Next slide. And our one of the problems that the county experiences with their crisis response is just the geography of Orange County. I know it's nothing; it's LA County dwarfs our geography, but there are definitely challenges with response time, and because we have this hyper local approach, which is city by city, our average response time is 13 minutes. The time on the scene is about 42 minutes, and you know, if you think about that, the aggregate hours, we're pushing like 5,000. So in terms of that offset for law enforcement or EMT, this gives you, we are starting to get to some metrics where we can really, you know, start thinking about that and thinking about resources saved, but also those are hours that that law enforcement can be spending doing public safety and the, you know, the other things that they're trained to do. Next slide. So 66% of our calls don't require any co-response. So that means that, you know, we're not responding with police or with the fire department or the CAT team. And we're pretty excited by that because that was very much the thinking here that a lot of these calls could really be de-escalated in the community. Next slide, please. And then overall, 85% of the calls are stabilized in the community, meaning that they don't need to be transported anywhere. We don't have to take them to a CSU or an emergency department or anything like that. We're able to take care of the needs, get them stabilized in the community. We do establish some relationships with folks, and we do follow up care management and also a little care coordination to get them connected to resources that they need. And now that CalOptima is bringing online street medicine, we anticipate having more coordination with them around that. Next slide. And then you can see from this that about 65% of the people, the calls that we have done are to the unhoused. But this is actually really important because a distinction that we were making with the service is that it's not just for people experiencing homelessness. Now, it's, the city is definitely are appreciating the fact that we can be deployed to address some of the needs of the homeless. But the idea that we can go, we basically go anywhere where a 911 call comes and somebody's in crisis. And that's all I have. I think that's my last slide.
I couldn't find the unmute. Well, thank you. That's a wonderful presentation. Let's see if we have some questions about that last part. I don't see any. Okay, well, thank you. I guess you answered all of the questions.
Dr. Gold, there is one question in the chat, if I could read it for you.
Of course.
Okay, so Lily Sofiani from Supervisor Mitchell's office said, that's a beautiful model here. Question, does the fire not come out to do an initial health screening during the first call contact? Who does the screening at first contact to make sure the doctor is not needed?
No, fire doesn't go out for that. Basically, because the calls are going through dispatch, the dispatcher is the entity that makes the determination about what's the best deployment strategy. And so, we do have, as I mentioned, people with medical training, with EMT training on the rigs, but so they can do a quick assessment, but that's not really, what we're about. We are definitely, trying to, this is about de-escalating and addressing the needs of people who are experiencing, mental health issues, substance use issues. I mean, they're really in crisis, and they're people who are really at risk of escalating and then needing a higher level of care. And what we're trying to do is take care of that, so that and preventing, the need for that higher level of care.
Okay. Alex, I think you were next.
Yeah, I think I have a couple quick ones here, I think. One is about the dispatch system, whether it's a county level dispatch system, how you've got different cities. How do you deal with the patchwork there, or if there is none?
Yep, it's patchwork. It's city by city.
So each city, are they running their own dispatch? And so therefore they're, wow, okay.
Yeah. And we have the, the matching computers on the rigs, so that's how we get the calls.
Got it. And I mean, that's fine when you've got your own, we have a regional one, which creates its own problems, and we're trying to figure that out with our own crisis response. And then, and so it's that dispatcher is also making the decision about whether there's a co-response or just the Cahoots style response, right?
Yeah.
Okay.
Yeah.
And then I think I understand this, but the question I got by text is whether this is, my understanding is that you're serving about 2/3 of the services to calls for service on unhoused individuals. Is that right?
Yeah, we've seen some variation over the course of the year. It's been as low as 50-50 and as high as like 70.
Thanks. Thank you very much. That's all I had.
Sure.
Aramis?
Thank you. I have a quick question about the dispatch. Since you guys have your own rigs that are going out to the community. Did you guys have any pushback from your local fire department or police associations when it comes to, you know, that EMS person on that rig that's, you know, doing a quick, you know, assessment of the client?
Yes, and that has required, you know, we've had to do a lot of conversation. I mean, there's a lot of communication that's needed. You know, there are definitely union issues and that sort of thing, but we're super clear about what this service is and what it isn't. And we do not transport anybody like to a hospital for a physical health need, anything like that. Our protocol would be to call EMS for that, or call fire. And you know, on the law enforcement side of things, what has been really amazing actually is just the experience, the more experience that we have in the field and the more experience the officers have with our teams. They're developing relationships, and there's, I think, a real appreciation of an alternative to law enforcement having to get deployed to these calls that, you know, really they're not equipped to deal with. And, you know, it's a really nice handoff for them. And, you know, the other thing that happens is we do get deployed with from 911, but we also, if the teams don't have any calls, they do drive around and they go to some of the areas of the cities where we know that there are, you know, potentially levels of need, that where we want to do welfare checks and that kind of thing. And so the teams are actually out on the street a lot, and they're coordinating with the outreach and engagement workers that the county deploys. And you know, we're still really, you know, I think that this service in a lot of ways is continues to be underpotentiated, because when we actually get the model to maturity, I think that we will have more workflows with the range of resources that are unique to each of the cities and that sort of thing too. I mean, that's really a goal. And so we meet with the cities and with the broader programs in the cities monthly to make sure that we're getting that level of coordination. And, you know, we're you know, like I said, this is kind of a proof of concept and we're still evolving it, but it's very much with the intention that I laid out, which is, you know, de-escalating people, preventing them from, you know, needing higher levels of care, and then also creating a more coherent resource system, making sure that, you know, we are actually supporting the other entities that are serving the same population, but the resources are better aligned, or we're creating access points and that sort of thing.
Dr. Gold, we have a question in the chat, if I could read it out. This is from Elizabeth Anderson of the City of West Hollywood. Will the street medicine component be rapid response like the mobile units, or engage in serving people at a different pace?
Gosh, that is such a great question. And I don't necessarily have the best answer to it. I know that the CalOptima has their RFP out right now. They're doing interviews, and I don't know the full model that they're envisioning, but I don't believe that it's supposed to be a rapid response. They really, what their rationale for doing this is that they believe that anybody who is unhoused in Orange County is or should be one of their members. And so they want to be better serving their members and getting services to them, and then getting their members connected to a medical home. So I think that my basic understanding is that it will not be like a rapid response emergent deployment. It'll be going to places where they know that that there are, you know, people in need of the services that they can provide.
Okay, well, again, Karen, a great presentation. Thank you. We've got please hang around. We've got about 20 minutes left in this meeting. And I think there's a need to sort of talk about, you know, next steps, if there are to be next steps. You know, the first question is it something that we collectively as a West Side community would be interested in entertaining? And if that were the case, then we can talk about all the things that it might take to get it done, which I'm sure would be quite the lengthy list. But I think the first conversation is really around is this something we would even want to consider? And so I kind of put it out there for anybody who'd like to open the floodgates on the conversation. Alex, you were first.
Thank you. It really seems like this idea that we pick a project and figure out the challenges with those guiding principles is exactly what we need. So I'm open-minded. I love the idea of a facility and rallying people, healthcare providers around that, because there are huge gaps. Everyone thinks, all of our residents think that we're being mean and preventing people from connecting with services, right? And we all know that there's a pretty threadbare patchwork out there, and not really a great mechanism to get them to it. So anything that we can build together, if we all agree on what is a gap that we're experiencing, and especially with our county partners, I think would be amazing. And I'm certainly game, assuming the voters of Culver City allow me to stick around.
All right. Any other thoughts? Yes, Lauren.
Yeah, I mean, look, it's a regional problem and we need to have regional solutions. So us working together on a regional solution is optimal. But I know that West Hollywood has been doing a lot, and we are actually forming our own mobile behavioral crisis unit. It's not, I've been quiet because I actually had seen the presentation previously. And thank you so much for that, Karen. What I see the need is the regional center, a center that has the different levels of housing and care, the facilities. That's where I really think we're lacking. And I think that's where the county has sort of fallen short in terms of this whole Measure H, what they've been providing. So I would, I know that Sue has talked about that before, that there, may be some partnerships happening with the city of Santa Monica and a hospital. And, I would love to see that explored more. But we also need the facilities.
Thank you. Sue?
So I sort of stumbled on OCB Well, which I think is a pretty out of the box approach to the problem that none of us have thought of. And I think we're all looking for out of the box approaches. We clearly are not dealing with a crisis on our doorsteps. And I think that with the shortage of mental health services, mental health beds, and like West Hollywood, look, none of us are really sitting back and not creating our own mobile crisis teams, mobile this, outreach teams, et cetera. We have our fire department already has a special unit to do it. I just have to say, I'm not saying that anybody, I don't think, and Karen, I want to ask you this question since you're still here, because you talked about the fact that each city sort of does their own thing. Look, I'm a big believer in collaboration and in cooperation wherever possible. I think that more is better than, more of us working on this problem will be more effective than one city or even two cities. I mean, if we could do it all 88, but obviously that's unwieldy. So we have our COG. We're all pretty wealthy cities that actually have the ability to put resources into this. And we also have healthcare providers who are willing to put resources into it because frankly, they don't individually want to build the beds that all of our communities want. And that was how we got to this. So instead they'll put money into something that they aren't running. So then you get to the public-private partnership, to having all of them partner. And as I say, we need glue to hold this together. And Karen, can you help me on this? Who was the unifying force, or what was the unifying force as you brought this together?
For the whole Be Well?
Mm-hmm.
Well, I think that's a very good question. It really was what I described initially, where there was an agreement with the hospitals in the county and some other entities. I mean, we had Saddleback Church, we had some well-recognized and esteemed entities in the community that came together and said, yeah, let's do this. It was also really important to have something like Mind OC as the organization, as the neutral Switzerland, to help facilitate that, because that's really what our role was, at least initially. I mean, now we've gotten into the business of filling gaps and identifying where there are needs, and then we make things happen. And but it's, you know, it's slightly different. And then, you know, to your other point about just the city.
Did you say My OC? Is that
Mind OC?
Oh, Mind OC. So
Yeah.
do we have the functional equivalent of that in LA? Is there a Mind LA? I'm not joking.
Not yet.
No, I'm still asking Karen. I mean, Karen, you think I've released you from this, but I have
No,
not.
I mean, well, you know, we started it because we didn't have anything. I mean, it could have been, you know, people talked about the United Way. They talked about, you know, organizations that already exist, but by definition, if the organization already existed, they had a stake that wasn't necessarily, you know, neutral.
So what was special? This is what I'm trying to understand. So you guys formed out of nothing and then drove it forward.
Mm-hmm. Yeah. And we did have some foundation investment. We had some money from the California Endowment, from UniHealth, from Wellbeing Trust, you know, a little bit of stuff. And then, you know, some of the health systems put forward some resources. But and then, you know, now, like with mobile, we really started mobile. We've gotten our philanthropy side of the house going. And so there are a number of wealthier donors who have had, you know, touches with the mental health system where, you know, they had tragic touches, or, you know, couldn't get services for their children, that sort of thing. And so they were very willing to donate the vans and that kind of thing. So that's how we started that. And then, you know, to your other point about we're in 5 cities, we actually, our goal is to actually move this more into a regional approach, but each of the cities needed to kind of stand up the program way that they wanted. And now they're starting to recognize, oh, we actually could share this resource, or kind of come together, and maybe, you know, we would benefit from a regional approach as opposed to city by city. But, you know, honestly, every city has a different, like the background checks, all of these processes are city by city.
Well, what I do wonder is if you scale up, I mean, and we've seen it in LA, it becomes unmanageable.
Right.
So I'm trying to think about what piece of this we could, if it were just this COG, and it could be that there will be a different combination of groups that do this. I think Santa Monica is committed to the program. I hope it's the COG, but if it's not the COG, I think we'll be looking for some kind of collaboration somewhere. So Cecilia, do you think this is something the COG could actually be a driver in?
I think we could be, if there was consensus among the members of the COG that this is what you wanted us to prioritize. But I'll also say, quite frankly, Sue, is just as Karen noted, there needed to be some funding to fund this. We'd need that, because right now we carry out our program, and stepping up to this level would take additional staff resources, which we're just not funded for.
So Karen, to that end, let me ask you a question. Could we create the facility piece without anything else? If we made a decision that, because we all do provide a lot of those services already, and those services could easily feed into a facility if there was one. But from a conceptual point of view, from your experience, does that make sense? And would that in some way impede our ability to be successful?
I don't think so. I mean, I think that you really could start with something like that. I mean, what I didn't talk about today is a very important component of the movement, which is, you know, this coalition and the community engagement that we do, and the you know, kind of the penetration that we have into the community. I kind of talked about that, but that is actually another unique aspect of this. So it wasn't just a matter of building and co-locating services and you know, getting entities to donate into that building. It's the community's broader recognition that that something is changing, that there's a commitment to change and there's a commitment to doing business differently. And a lot of that comes, you know, by seeing the building, but it's also around the narrative that we are co-creating with the community around what they want to see, and you know, really feeling a part of this. So I think it's less about kind of the different projects that you might do, you know, your portfolio of interventions, if you will, in this, and more about, you know, making a decision. Do you want to kind of have that broader collective impact frame where you bring the community in?
But isn't that kind of a chicken and egg thing? I mean, so I use as a for instance, you know, we talked about the competition amongst health systems, but there was a recognition that the number of rehabilitation beds in this side of the town was very limited, and it brought UCLA and Cedar together to create a rehab hospital in what used to be Century City Hospital. Very effective, very full, very needed, very successful. That same sort of energy, the recognition amongst those health systems that this is needed, and the recognition by our cities that this is needed, does bring us together in a cooperative that would in effect create a facility, could create a facility, and that facility, by virtue of everybody's participation, could drive a lot of the learning that you're discussing. Couldn't it work that way?
Yeah, sure, definitely. I mean, because you also, I mean, what you just described could be considered a community, you know? I mean, you have, it's a cross-sector approach that, you know, is trying to make a difference in that geography.
Right. Lauren, is your hand still up, or is that a second time, or wasn't sure?
Sorry.
Okay.
I forgot to take it down.
Okay, so I'm just sort of taking temperatures here. I heard a yes from Alex, a cautious yes from Lauren, maybe a slightly more cautious yes from Sue, and I haven't heard from Phil yet. I see his face, and
Councilmember Nazarian had her hand raised, and then
okay,
something into the chat.
Sharona?
Hi, thank you. I just put it in the chat, actually. I was just curious if we have a location in mind that's central, and also if we have any land restraints that we need to be aware of for a project such as this. I noticed that the project that was presented by Karen had a really great piece of land and space that you were able to use for the facility. Unfortunately, the West Side cities are a lot more saturated. So has that been something that's come to mind?
I don't think we've gotten that far down the rabbit hole. That would certainly be a question we would have to answer if we agreed to move forward. I think the real question I'm trying to get to at the moment is, do we want to move forward? But I think you're right. It's an important question, because we could decide we want to move forward and it's just not feasible. So that would be a second step. Sue?
Let me just say that you characterized my support as more lukewarm than Lauren's, but actually it really isn't. I mean, I brought this or proposed this to the COG. I'm a really big supporter of this, and whether the COG does it or some other organization that I'm involved with does it, I think it's going to happen. I think whoever does it is going to be a winner, as Karen is. And I think that if we don't do it, we're missing a great opportunity for all of our cities.
Well, thank you for that, and thank you for clarifying it. And I'm sorry if I mischaracterized what I heard. Bill?
I just want to, I think, echo Sue in that I think we would be very enthusiastic. You know, the quandary, of course, in the west part of LA is empty land. There may be a site, Sue, is a site that we were talking about next to SMO possibly available in LA?
So there are two sites at Santa Monica Airport, which one of them is probably available now. I'm not sure if the other one is. There are two alternatives. I like the southern one better, but it's right off of Bundy. So it is pretty central for everybody except, look, there's nothing, three cities are all west side, but not necessarily contiguous, right? But I do have to say that, look, I was at the emergency room last week, and LA, actually, I think it was not even West LA. LA brought in somebody to the emergency room who left before the police were able to leave. I mean, this is a problem we all have. And I think that that even though this is far, our site, and look, I'm offering it up without talking to the city and not being one of the people to vote on delivering it, but we have 2 potential sites. And Karen, let me ask you a question. How many acres is that Irvine site? It's a little less than 2, right?
Oh, the Irvine site is huge. It's
75,000 square feet.
The one where we built the Orange County, or the in the city of
Orange one, yeah. How much was
Yeah,
that?
that's about 2 acres. It's much smaller. That's why we built.
But the
2.
Irvine, I thought, was 56,000. That's almost 2 acres, right? Isn't?
Or is there just
I'm
a
sorry,
lot
I
of
thought it
open
was
space?
75, something like that, right?
Oh, that's just the
40,000.
square. That was the square footage of the buildings.
What's the square footage of? I thought it said it on the slide, and I'm sorry, it's not in front of me, but I thought when I looked at it, right? In
We
acres
have
for-
the phase one of the buildings is 23,500 square feet. Another one is 37,400, and the
But how big is the site, Karen? I'm sorry, I didn't mean to mislead you. It was on the slide, I thought.
It's several acres. That's such a great question. Sorry.
So Karen, it's larger than the Orange site.
Yes.
And actually, because you have more outdoor capacity.
Correct.
It's important as well for rehab and taking care. So I can let you know, at least on my part on the city council, I will continue Sue's work on this. And we are extremely enthusiastic supporters of getting this done in conjunction with our local hospitals. And I think the example that I had heard about for a long time from Orange County is from you, Karen, is just a stellar example of what we need to do in our cities on the west side. So I think in conjunction with the city of LA and Santa Monica, there is a site on Bundy just south of Airport Avenue. And there may be another site in Santa Monica, and maybe some of your other cities have something too that we can look at. But I think we need to do it. And I think we need to pursue this as soon as possible.
Great. Lauren, is your hand back up?
Yeah, I just wanted to agree with Sue that I didn't think I was being cautious. I thought I was saying that a regional response is necessary because as you know, our homeless count may go down this year, but yours went up. So it's a regional problem. So we all need to work on it together. There just
Okay.
might be different pieces, parts that we need more than maybe one city needs more than others.
Well, and I appreciate the clarification. I didn't mean for you either. I just wanted to hear, yay, let's do it. And I guess maybe not. We didn't do that. Anyway, I think we're all there. Yay, let's do this. And I think that the real question next is how. What would be a way for us? Maybe Karen, with your advice moving forward, and Cecilia, I kind of look to you to help us define a thoughtful way to work through how we would advance this relatively quickly, what services we might want to provide, what is the relative contribution of each city in whatever form, all those sorts of questions we're going to have to answer. Karen, if you have a working template for how you kind of work through the checklist of, you got to do this, got to do that, that would be helpful too. But I think that there's urgency to this. And I think we need to develop a process forward quickly. So
let me just, Dr. Go, let me just say, I appreciate it. I heard, yay, let's do it pretty clearly from the board. So I think that that's a priority for us. And what we can do is certainly circle up with your team. Obviously, we already work very closely with your housing and homelessness folks. This is part of our work plan in an exploratory way. But I think if the folks from Santa Monica, Phil and Sue, if you're okay with it, I think the fact that the facility, that physical location is really the key. Every city would like to see that happen. And maybe we use that as the organizing principle. We'll work with your team to kind of figure out where the process is. maybe circle up with others to define the steps. And Karen, you've been so gracious with the time. People are always asking you to do this presentation, and I appreciate that. You also have a project to run. If we could even just check in with you one more time, if with our kind of our work plan, that would be most appreciative. And we really do want to respect how generous you've been with your time with us. But we'd be happy to do that. We have a board meeting coming up in a couple of weeks. We had tentatively included an update on this as one of the agenda items. We'll move forward with that, at least with a preliminary work plan of next steps that we'll bring before the board at that board meeting, if that's okay with y'all.
Yeah, I think that's great. I think if we can get this in front of the board at our next meeting so that we can tweak it or whatever and move it along, that would really be important. Great.
And I should add, Cecilia, that we've done a couple, I think, of RFPs around these issues just to figure out where, so you know where we are. And right, thank you.
We will be back in touch, and we are right on time with this meeting.
We're trying. Okay. So if there are no other comments from the board, no other thoughts, I'm prepared to adjourn this meeting to our next meeting on October 13th. I thank everybody for your time, your participation, and your thoughtful guidance. Karen, special thank you to you. As Cecilia said, you've been very generous with your time. You've done an amazing job. We all appreciate it. And it's something we all aspire to continue. So thank you.
Thank you.
All right. Thank you all. We'll see you on the 13th.
Thanks, everyone.